Thank you very much. It's a pleasure being here. All right. I'll start off. Right. Life is not perfect. We have children like this who present to us. And in our setup in Malaysia, the pediatric glaucoma work is done by pediatric ophthalmologists. It's not done by the glaucomatologists. So it's challenging in many ways. Yeah. So there are a few of us who have taken up this task, and I've been one of them, and I've been doing it for a few years now. Right. The thing with these children is a clinic examination is always not easy. So most of the time I spend that I was just getting an idea and basically counseling the parents, telling them that it's a long process, surgery is not once, most of the time there'll be repeat surgeries. And mainly we get the examination done under anesthesia in our setup. And we prefer to start off with ketamine. We use ketamine to check the IOP. We find that we give it first, we wait a few minutes, let the IOP settle, and that we find is the most accurate way compared to the inhalation anesthetics, which tend to drop the IOP. And we use the Perkins. That's been our gold standard. Takes a little bit of practice, but over time we've gotten good at it. Now we've also had the iCare Pro that's very useful. It's a added armamentarium in our practice. It's quite comparable, but once if it's a dysgenetic eye, then we don't get very accurate pressures. We still go back to the Goldman's, Perkins, sorry. Right. Now, the remainder of our examination is basically done with inhalation anesthesia, where we actually proceed with the anterior segment examination. Then we do the corneal diameter measurements, gonioscopy where permissible. And if the cornea is clear enough, and if it's a repeat examination under anesthesia, then we go ahead with the fundus examination and on-table refraction. This is generally how we've been doing it over the years, and we maintain that. Right. Now, what are the objectives of treatment in a child with pediatric glaucoma? Now, one of that is keeping the IOP in a respectable range. That's now we've accepted it as about 15 millimeters mercury or lesser. And also to look at the other signs for no progression. That is, the corneal edema settles down as much as possible without recurrence. Myopia doesn't progress, because we know progressive myopia means that the pressure is not being controlled. And of course, looking at the optic nerve head, and to make sure that the optic neuropathy or the cupping is not progressing. Right. Now, in terms of management, drops in the smaller, the toddlers or the younger children, it doesn't really work. It's just basically to temporize. And we basically go towards beta blockers like timolol, or the anhydrase inhibitors like dorzolamide. We don't use your prostaglandin analogs in this age group because they just don't work, and it causes a lot of hyperemia. We don't use brominidine because we've had a bad experience. You end up with apnea in these babies or children if they are very young, those below the age of 4, so we keep away from those. But at the end of the day, for the younger age group, those to us, less than 8 years old, surgery is most of the time the definitive management, yeah, in our practice. And coming back to the presentations now with the PCGs, of course, we all know the triad of epiphora, blepharospasm, and photophobia come with ophthalmic eyes, diameters normally more than 12 millimeters. They get corneal edema to various levels, and of course the HARP striae. Now, in our practice in Malaysia, we don't get very clear corneas most of the time, so we tend to have moved towards trabeculotomies. That's our surgery of choice. Most of the time we get the trabecular meshwork. It takes practice. In 80 to 90% of the time, 20% of the time we don't find it. It's difficult, because there can be some anatomical variations. And and with the refinement of technique, we find that we've gotten better with the hyphemas, and we don't damage the iris roots so much. What we tend to do is we tend to dissect with a Bard Parker blade. We don't use your 15-degree blades because it just cuts too fast. So this we can actually go fiber by fiber. We can get to a particular depth. And then we use the crescent knife, and we deroof. And when we do when we have actually reached the roof of the Schlemms, we can actually deroof it, put viscoelastic, push in a proline fiber in, and get the passage proper without false passage, and then pass in our Harms trabeculotome. Once you've done the first pass, and we're going to do the reverse pass, I actually put viscoelastic in, and that's through a side port, so that we can actually fill it up. If you don't do that, your AC collapses, and you tend to tear the root, cause hyphema. And over time, we have refined it to a certain extent that we are more consistent with our outcomes. Do we do combination? Yeah, I think now in India the trend is towards combination from the start. We tend to still do trabeculotomies. We do combination when we have to repeat cases or when the child is older, 2 years and older. Now, reason is because we prefer to use mitomycin C. We can do plain, but the failure rates are probably the same. So with a bit of mitomycin C, it would not be prudent to do it at a younger age group. So we go 2 years and beyond. And we tend to use very little, not too much, 0.2% over 2 minutes, and that's it. Right? Goniotomy, honestly, we don't have very clear corneas, so we've not had much, we don't do too much. Our experience is limited. It's technically more challenging if you are not doing it often. Yeah, with the ones we have done a few, the short scans and, with the tilting of the microscope, we do. But mainly reserved for our stage Webbers, I would say, because sometimes others don't work. Right, so we get this sort of children coming to us, horrible anterior segment dysgenesis. I think we have a gene pool in Malaysia, certain regions where you get more of these children coming from, severe aniridia with keratopathies, and they're very challenging. We get these. Of course, we also have the other secondary glaucomas, the aphakics. We try to put the lens in most of our kids, but sometimes we can't, and about 20% of them develop aphakic glaucomas, our Sturge-Weber syndromes, and of course the rare neurofibromatosis we get, all of them get secondary glaucoma. So in these cases, we tend to do one of two, the first one being our trabeculotomies with mitomycin C. We've actually, in our practice, we modified it a bit. We do larger peritomies. We dissect the tenons. We tend to do that. Again, here we use a Bart Parker blade again to dissect the sclera. It goes easier with the layers. Again, we can actually choose our depth. And we do mitomycin C. We use it a bit longer. We're a bit more bolder here. We give 0.4% over 4 minutes, right? GDDs, yeah, we've been doing that for some time. We started with the Ahmads. We didn't get good results, and then we moved on towards the Bauweld, and now we are using the RD from Aravind, and we're getting good results with that, fairly good, yeah? Here again, we stand to the proline, and we don't do the Sherwood's fenestration, so we find that it's just not, it's risky, and we overfiltrate, right? But it's not without its problems. Tell you we have problems. The ones are tube blockage, fibrosis, it becomes messy. Sometimes we have corneal touch, we've lost corneas also. We got conjunctival retraction, and recently we've also had this, where a child went for a holiday, came back with skin infection and endophthalmitis. We lost the eye. So these are not without its problems, full of problems, but we have to tackle them. If not these children, natural history, they go blind. Right, refractory glaucoma. This is something we do meet on and off. Like this child had trauma to the eye twice. The first time he had a bad corneal laceration. He had a traumatic cataract. We did a PK for him, got the lens done, and then he traumatized the same eye again. And this time he ruptured, he had a dehiscence of the graft, the subluxated IOL and a retinal detachment. And we had to go repair that, and what happened was he had severe PAS and a refractory glaucoma. And there's no space to do anything. You can't put your tubes in, you can't do your traps. So what do? No, early on we used to do the standard transscleral diode lasers, and we don't get good results, to be honest. It just lowers it for a while, and the pressures come back up, and it's just a battle. And now, what has happened in our part of the world, we've had Prof. Paul Chu from Singapore and US, who's been doing a lot of work with micropulse lasers with the G6 probe. And we started using it on these children. And I know a lot of people say, this is dangerous, a lot of inflammation. You may, cause phthisis and all that, but not really. We've been doing it in a fair number of children. We've got about 20 to 30 kids who have we've done this on all refractory cases, yeah? We don't use it as a first line of modality. And we've been getting fairly better results. Sometimes the treatment needs to be repeated, maybe twice, 3 times, and we tend to stabilize the pressures better. And of course, we may have to use drops after that. So It's very easy actually to do this. You just need to, prep the child, use viscoelastic on top of the conch, and then just use the probe and roll it superiorly, inferiorly, leaving the 3 o'clock and 9 o'clock positions free. And you can do it for about 50 seconds to 120 seconds on each half. Yeah. So far, I've not had any real problems with it. Sometimes some mild pain, discomfort, but not really. And of course, the very advanced cases, we could get this sort of children, and we can't do much for them. So what we do suggest is sometimes to the parents, it may be a bit painful, is to enucleate the eye, because they run the risk of trauma, rupturing. We've had that before, and they do agree, and we do get good results. We get nice processes in, and implant processes in, and they look much better. Yeah. So that. Sorry, I rushed through because I know we have 10 minutes. So that's a nutshell. So I've actually put up a summary of how with my practice in care, limited practice which we have there, how we go about doing our cases. And for the PCGs, it's easier. We have a more cut a logarithm in the sense that the below 2s, you either do a trabeculotomy. If you're better at goniotomist, then you go ahead. The 2 to 6-year-olds, you can do a combined trabecular, and the older ones, they do better at trabec MMCs. And you can do the GDDs as something to fall back on. Now, these genetic cases, it's a toss between your GDDs and your trabeculotomist MMC. Now, if they become refractory, then you go ahead with your cyclodestructive procedures. And the same goes for your aphakic glaucomas. And the stage Webers, you can try your goniotomies if they're a bit younger. Later on, it's basically GDDs. Or if it really becomes refractory, then it's cyclodestructive procedures. But all in all, pediatric glaucomas are difficult. Not many of us want to go there, but it's something that we have to do because the natural history is they lose their vision and they need help. Thank you very much. Thank you for your time. Yeah.
It was a wonderful and comprehensive talk on how to manage pediatric glaucoma, covering all the practical points also. Would anyone like to ask any question from Dr. Sundar? Okay.
Not yet. I know we have the probes that have been passed, but we really haven't gotten down to that. I think if we were to do the standard trabeculotomies in our hands, and we do get fairly good results, and we seem to be refining it over time. So I think, and in terms of cost, I think it works out to being cheaper also. We have to look at it.
Some of us are doing inferior trabeculotomies.
Sure, yeah.
You cover more of the mesh. And it has been pretty effective. But the only issue is you cannot do a trabeclectomy inferiorly.
Correct.
Otomy alone.
Yeah. Yeah.
That's something we have done to overcome the cost of
the 360, yeah. That's a good idea. Something to think of. Thank you. Thank you very much. Thank you. Okay. Thank you very much. Thank you for it.
So now we move on to the